Hello and welcome to 502 Conversations. I'm Brian Kirby. My guest today is Editor-in-Chief of JAMA and the JAMA Network, Dr. Howard Bauchner. Dr. Bauchner, thank you very much for being here today.
Thanks for having me, Brian. And really, you feel free to just call me Howard.
And JAMA stands for Journal of the American Medical Association, but it is referred to as JAMA, so that's how I will refer to it. I have a brief bio on you, which I will read, and then we'll get to some questions about current events and JAMA in general. Dr. Howard Bauchner was appointed the 16th Editor-in-Chief of JAMA and the JAMA Network in 2011. Prior to JAMA, he was a professor of pediatrics and public health at Boston University School of Medicine and Editor-in-Chief of Archives of Disease in Childhood. At BUSM, he was Vice Chair of Research for the Department of Pediatrics and Chief, Division of General Pediatrics. He is a member of the National Academy of Medicine and an honorary fellow of the Royal College of Pediatrics and Child Health, United Kingdom. At JAMA, Dr. Bauchner has focused on publishing important and novel research articles and on special communications, improving and expanding clinical content, and using electronic and digital approaches to enhance communication and ensuring a commitment to innovation. Since your arrival in 2011, followers on social media have increased from 13,000 to approximately 900,000. JAMA now reaches over 1.5 million physicians each week worldwide, and views have increased from 10 million a year to 34 million, and podcast downloads from 300,000 to 3.3 million. Thank you so much for being here. And you have done a lot of work with all those increases in followers and such, I must say.
My pleasure. It's not just me. It's a large staff of people who've been remarkably committed to trying to expand the way in which we communicate information.
And we kind of scheduled this a couple of weeks ago and I started working on questions, but in this day and age, 2 weeks is a long time. So things have changed. I have some questions about COVID-19, of course, some about JAMA and the publishing. And so let me just start with some current events because this was big news this week. On Monday, Pfizer announced via press release, I should say, that results from its phase 3 trial indicate its COVID-19 is at least 90% effective with no serious side effects reported. And they're discussing with the FDA the duration of safety monitoring. So the data has not yet been peer reviewed, but the initial analysis was done by an independent committee, at least that as far as I read. So have you seen the data or have you spoken with anyone that has?
No, and I think it will be held confidentially by the Data Monitoring Safety Board and the company, and then ultimately the FDA. I do think the data will ultimately be shared with the FDA advisory panel on vaccines. So the goal is that there'd be a number of independent committees or groups of individuals who see the data. And so the Data Safety Monitoring Board advises the company, and then the FDA advisory panel will advise the FDA, although obviously it's the FDA that will make the final decision. I think it's wonderful news that it's 90% efficacious, but the real issue is that will have boundaries. So it could be as high as 90%, but it could be as low as X, and we don't know what that X is yet.
And when they say 90% effective, I don't have these numbers, so maybe you can help me out here. I can't remember if this was a 30,000 trial with 20,000 getting the vaccine and 10,000 the placebo, and I think they said they've seen 94 cases of COVID-19, I assume, in the placebo group. If it's 94 or 90% effective, to get that number, are they saying that they only saw 9 cases in the vaccine group, or how do they derive that?
It's a bit more complicated than that, but yet essentially they compare how many people got disease in the placebo group and how many people got disease in the vaccinated group. And then through a number of different types of mathematical formulas and manipulation, they can estimate the efficacy of the vaccine. Part of the issue is I don't know the details of this trial and if they have enough data to talk about efficacy in the highest risk groups, which are the elderly.
Let me back up a little bit because on October 6th, you wrote an editorial reassuring the public and clinical community about the scientific review and approval of a COVID-19 vaccine. Why did you think it necessary to write that piece?
Well, I think at the time, and as you've already alluded to, there has been a number of changes over the last few weeks and few months. I think in September and October, there had been concerns that it was possible that the executive branch was going to try to influence the review at the FDA, like they potentially had influenced some of the statements coming out from the CDC, although that had been reported how detailed their potential imprint on some of the CDC documents is unclear. And so I think there was concerns that it was possible, particularly to the run-up of the presidential election, that it would have potentially been in the interest of the current executive branch, President Trump, to try to get a rapid approval of a vaccine. And there is always the possibility of White House pressure on the FDA. And so that's what precipitated the editorial.
And just yesterday, current events, there was a research letter published, Speed, Evidence, and Safety Characteristics of Vaccine Approvals by the FDA. And that looked at over 21 vaccines from the last decade. And I just want to go over that because we're still at this warp speed. And so most required about 8 years of clinical development, and they were based on a median of 7 clinical trials. And at least 2 of those trials were randomized and masked and used a comparison group. And then they were followed up for serious adverse events for at least 6 months. And I think the last sentence I took out of that was, given the urgency of developing a COVID-19 vaccine, trials will need to be larger than those supporting prior vaccine approvals and include sufficient follow-up time for emergence of adverse effects. I know it just came out yesterday. Can you define larger trials and sufficient follow-up time?
Well, larger trials will ultimately depend upon how effective the vaccine is. So you do an interim report, and if you reach certain targets, then you may not need to enroll more individuals. So that will vary. I had interviewed Paul Offit, and Paul was instrumental in the rotavirus vaccine, and they had anticipated an initial sample size, I think, of 30,000, but the ultimate trial grew to 50,000 because they didn't see enough disease in both groups to really know. So the size of the trial will vary depending a bit upon how much disease they see. So if they had done this vaccine trial in areas of the world where there was little or no disease, then they'd need a larger sample size, assuming the vaccine is effective. If they do it in an area of the world where there's a great deal of disease, then they may need a smaller sample size. That's the issue around whether or not the vaccine is effective. That's a very different question, though, about safety. And I think people really need to distinguish between those two. And I have to say, most public officials, most public health people, most ID people have repeatedly said it's not just effective, it needs to be effective and safe. Safety is more complicated in the sense that no one ever knows the necessary follow-up time that is necessary. In this case, with the Pfizer vaccine, we're working in a new area. And I think there is some disagreement about whether or not you need 2 months of follow-up or 4 months of follow-up or 6 months of follow-up. I do think there'll be ongoing surveillance after the vaccine is approved. But I think for many people, some people will be happy with 2 months of follow-up. Other people are going to want 6 months of follow-up. There's no truth to know exactly how long follow-up should be. Longer is better than shorter, but when you have 125,000 cases a day and more than 1,000 deaths, there is an urgency to try to get to vaccine approval more quickly.
And when you mentioned ongoing surveillance, that's common for all vaccines, right? And so if this gets approved through an EUA, or if any vaccine does, that doesn't mean they can't stay in development and eventually get licensure and keep following, or?
Correct. They may move from an EUA to licensure. It requires more data, more follow-up for licensure. I think at the recent FDA advisory panel, which was held, I think, about 2 weeks ago, Brian, there was some disagreement amongst the committee members who are advising the FDA about what they would like to see in terms of follow-up. Some people have reported that traditionally major adverse events often occur within 2 months, but these are new vaccine platforms. So the question is 2 months sufficient? And I don't think the committee knows, they can't be sure. and there may be disagreements amongst the committee members.
And also, I guess I should ask you, this is the first vaccine out of the gate, it looks like, but there are many others in development that'll come along as we go. I think that's been mentioned a lot, right?
Oh, yeah, there'll be, yes, there'll be others from American manufacturers, there'll be others from Chinese manufacturers, European manufacturers. So I think they'll come from US manufacturers and companies, they'll come from European companies and manufacturers, and then clearly we published an article, JAMA published an article from China. They used a more traditional approach, but they certainly are also developing vaccines.
I want to ask you a question about pediatrics. You are a pediatrician.
I am.
And not only editor-in-chief of JAMA and the JAMA network. And my numbers may be off here, so please just correct me if I'm wrong. I want to be corrected. I want to get the accurate information out there. And, but on Monday, the American Academy of Pediatrics published that there were almost 74,000 new child cases reported the previous week because it's trailing data. That's the highest weekly number to date. The week before, they reported over 61,000, which was the highest number to date. So it doesn't sound like, you know, we're starting into a slump and this is starting to go away. So what's your assessment of where we are now, or is it still just too early to tell? We have no idea where we are.
Oh, no, we do know where we are. You know, I had done many interviews over the summer, and many people, including Dr. Fauci and other public health individuals, were concerned about the so-called winter months and the comorbidities of COVID-19 and flu. Now, flu, I haven't seen any reports indicating that flu is yet circulating. It's November, it should circulate shortly. I haven't seen any reports on the percent of individuals who've gotten flu vaccine. I would hope it's higher than it has been in previous years. But this was a great concern that as it gets cooler, you move people inside, that there would be more disease. In addition, it's really quite clear that there's no national mandate around masking. We've opened up colleges, we've opened up football games. So I think the reports of 100,000 cases, new cases a day, although disappointing, are not surprising. Now, there is more active surveillance, so there will be more cases. And the good news, if there is any, is that the case fatality rate continues to be low. Now, you are beginning to overwhelm hospitals and intensive care units, but the mortality rate for people admitted to the ICU and not ventilated is lower now than it was 6 months ago.
And I think part of what I wanted to ask you when I said, where are we now? I kind of meant in terms of the pandemic as well, because people will say we're entering a second wave, a third wave, or we're rounding the corner, or we're in the middle of it.
Well, it depends on what definitions you want to use. Some people would argue the US has never gotten to a very low number of cases. But if you look at curves, they certainly peak, come down, peak, and we're in that third peak. But people would say the trough has never been very low in the United States in comparison to other countries. That is the number of cases per 100,000. And it varies from state to state. It's always hard to compare a European country to the United States. I mean, people often like to compare Sweden to the United States. Sweden has 10 million people. We have 10 or 15 states that have more than 10 million people. So I'm always somewhat anxious about the comparison of small European countries to all of the United States. Some states in the United States, Maine, Vermont, have done particularly well. Other states, obviously New York, Connecticut, have not done nearly as well.
I want to talk about JAMA in general now, and so about the publishing and the editorial and what you do there. And this is really about science and studies, which I'm interested in, and I guess it branches into public health. So can you speak briefly about the submission and the peer review process? And what I'm asking there is when Dr. Fauci or anybody says that, or they emphasize that they've seen studies, but they haven't seen randomized controlled placebo trials, what are they saying? What point are they making?
Well, there's a hierarchy in clinical trial research to define cause and effect. And that's because of a term called confounders. So say you just do a study where you just observe people and you want to know the effect of, say, smoking on dementia. And so you look at 1,000 people and 100 smoke and 900 don't smoke. And you find out that the 100 that smoke have a higher rate of dementia when they turn 50. And then you write that smoking causes dementia. That would not be accurate in the sense that the people who smoke may do other things. And you can't always know what those other things are. They may not exercise, for example. They may not eat well. They may have high blood pressure. So you conclude that smoking's related to dementia when in fact it could be the hypertension that those patients have. In a randomized clinical trials, if you could, and in this case you can't, you would take 1,000 people and you'd ask 500 to smoke and 500 not to smoke. And then you'd follow them for 15 or 20 years and say, well, let's find out how many of those who smoke versus don't smoke develop dementia. In that type of study, a randomized clinical trial where you've assigned people to smoke or not smoke, or to a drug and not a drug, you know both about differences at baseline, you've measured them, but you also hope that what you don't know about that could influence the outcome also is evenly distributed between the groups. That's why randomized clinical trials are so important. So JAMA published 3 clinical trials about corticosteroids. And those 3 trials, when you added them together, said that corticosteroids really reduces mortality in patients with COVID-19. And so the randomized clinical trial, and when you put randomized clinical trials together in something called a meta-analysis, they're considered at the best or the top of the evidence pyramid. It's either randomized clinical trials or meta-analyses of randomized clinical trials.
If that's the case, how did we get caught up in this hydroxychloroquine thing with a doctor in New York says this, somebody in France says this, randomized trials say that, but I'm going to go with the study, not the randomized one. How does that all interweave?
Well, that's a longer discussion. We just published the definitive study about hydroxychloroquine. It's from the PEDAL network. We just published it yesterday, and we also published it with an accompanying editorial by Mike Saag, SAAG. Both articles are free on our website. The PEDAL network is one of the preeminent clinical trials unit in the United States. Hydroxychloroquine did not reduce mortality among patients hospitalized with COVID-19 and seriously ill. And Michael writes about how did we get there? There was a preprint, describing in an observational study that some people who were given hydroxychloroquine survived and at a higher rate than those not given hydroxychloroquine. And then obviously it was championed by President Trump. And that's been one of the great concerns over the last 6 or 8 months, which is allowing politicians of all stripes, not just President Trump, trying to interpret clinical data, particularly preliminary clinical data. And so it's likely that thousands, potentially tens of thousands of millions of people got hydroxychloroquine when certainly now in hindsight, we know it was not effective.
Not infrequently, a newspaper or broadcast news or online service, they'll print a headline that says JAMA study shows this, or a new report in JAMA shows that. Do you ever read those news articles and just keep an informal tally of how much the headline or the story relates to the actual research, or if they botch it up altogether?
An interesting question, Brian. I'm often asked after there's a news report, could I write to that media outlet and tell them they made a mistake? JAMA takes great pride in both our press releases as well as the way we think about presenting information. So causal language is only used for randomized clinical trials. Drug A affected, drug A prevented, versus saying drug A was associated with. So we only use causal language in randomized clinical trials. Secondly, we always give absolute differences. If you give relative differences, you can always make something look really good. So say something occurs in 1 versus 100,000 versus 2 versus 100,000. You could say a drug was associated with 100% reduction in mortality, but the absolute difference was 1 in 100,000. So we always give absolute and not relative differences. How that is often picked up by the media is really not under our control, but we're very careful in the language that we use, both in editorials as well as in original research, to make sure of the language we use and to always present absolute and not relative differences. We also tend to cite the major limitations so that they'll be reasonably apparent to the reader. I would say, in general, the major media outlets generally do a good job in presenting the results of papers published in JAMA.
And what do you say to someone such as myself, a non-scientist? If the article's online, they usually provide a link, or you can find it online now. But so someone such as myself, that we're interested in reading some of the papers, but the p-values, the confidence intervals, and everything in parentheses we find intimidating.
Yeah, no, it's hard. I think for many clinicians in certain areas, genetics, artificial intelligence, those are really difficult papers to consume. You know, we write for the scientific community. We don't focus entirely on the public. We have patient pages that are really meant for the public. I think, you know, some people will consume the original medical literature. I think most patients, most members of the public try to get help if it's relevant to them from their clinicians, be that physicians, nurse practitioners, or nurses. And so I think the pandemic has changed it, because so much of the medical information is in the public domain so quickly. But in general, I think most patients are reliant on their clinician to help them interpret the medical literature.
Annually, I think I read on your site that only about 4% of the research papers that are submitted get published. And if that's the case, can you explain the value of publishing a paper that ends with no evidence to support the conclusion that X helps Y? Why is it important to publish null results? And I think just yesterday you published a paper or research letter on vitamin D, omega-3s, and exercise in people over 70 on their effect on 6 health outcomes. No evidence to support the conclusion of anything. So why is it important to publish that kind of a paper?
So that people stop using vitamin D supplementation or omega-3 fatty acids. So that there's a null conclusion, that there's no difference between groups, that may influence care as much as a positive finding. People often accuse journals of not publishing clinical trials that show no difference. I would say about a third of the clinical trials that JAMA publishes show no difference between groups, and they may influence clinical care or as much as a study that shows a positive finding. So in this case, if one were to read that article, one could consider, and they should talk to their clinician about stopping their vitamin D or their omega-3 supplementation. That's why it's particularly important to publish studies such as that.
And I want to ask about getting published in JAMA. If I see something in JAMA or JAMA Online, is that automatic validation, or is it an invitation to respond? And the reason I'm asking that is I have a quote here, and it's Dr. Stephen Novella. He writes, "The purpose of publishing in the peer-reviewed literature is not to declare victory for your hypothesis, is to put it out there so that other scientists can try their hardest to rip it to shreds. And if you don't have the fortitude to handle this meat grinder, then go into another profession." So when you see something in a journal, is that automatically the end of it? It's validated?
Well, I think it depends upon the journal, and I think it depends upon the study. I think many clinical trials are definitive. If they're well done and large, they do give definitive answers to clinical questions. But most of the medical literature is just trying to help shine light or on a particular question or series of questions, or add information to a complicated puzzle. Now, that's different for randomized clinical trials that are addressing a particular drug or a device, or new information about a particular device. Those are somewhat different questions. So I don't entirely agree with that quote. I think it depends particularly on the journal and the type of article that one is reading.
I want to go back to some of the things recently published, and you recently published in JAMA Insights, herd immunity and implications for SARS-CoV-2 control. And subsequently, you hosted a really great conversation between Great Barrington Declaration author Dr. J. Bhattacharya, I hope, and the John Snow Memorandum response author, one of them, Mark Lipset. And there seemed to be a lot of middle ground agreement in that conversation. I mean, it was really well moderated. Go ahead if you want to speak about that. I thought it was great.
I was struck by your comment that you thought there was middle ground. That was my take home. I didn't think they were nearly as far apart as the two declarations. Yeah. If you read the Great Barrington Declaration, it sounds like they want people to just go out, pursue their life, and if they're not high risk, not mask and not socially distance. That's not precisely what Jay said to me in the conversation. I think he was much more careful about saying, oh no, one should mask and one should socially distance, but we should allow people to go about their life. I think Dr. Fauci, Tony's been saying that for 6 months, socially distance and mask, but not to shut down the economy. It was very interesting because my take-home message was the same as yours. I thought there was more common ground, but I think if you read the Great Barrington Declaration, they talk about allowing people kind of just to meander around the country without a mask or social distancing. In addition, they don't really provide the details about how you would protect 100 million people who are at risk. And that is a critical question. It's not just the frail elderly. If you're 50 and you have health conditions and you're frail and you're overweight or you're hypertensive, you're at greater risk. So the question is, how do you protect all of those individuals? And I think the objections, many of the objections, just some, not all, of this notion of herd immunity is that they provide no details. In addition, other people have argued it is virtually impossible to acquire herd immunity for a society without enormous rates of death, 500,000, 1 million or 2 million or 3 million without a vaccine.
Well, you kind of just got into the question I had about that was, can you speak a little bit about this natural herd immunity and how it's proposed to work, and if there are successful examples versus the vaccine-induced herd immunity? And I think when they were talking about herd immunity for COVID-19, they came up with a 60% number, which is, 1 minus 1 divided by the R naught. I don't even know if there's an R naught yet. But if it is 60%, that's 200 million people in the United States that have to get it. And again, I'm not sure what the infection fatality rate is. I've heard as low as 0.5%. That'd be 1 million dead through that.
Well, some would say the current administration, because of its lack of focus, is pursuing herd immunity. Obviously, that will change on January 20th. I think even before that, given the number of increases, I think the governor of Iowa announced a masking policy today, the governor of some state that hadn't in the past, in part because that governor's hospitals are getting overwhelmed again. So it's true that the case fatality rates come down, but the number of people being hospitalized reached a record high. Now, the good news is that's spread out amongst 50 states rather than concentrated in a limited number of states. You are correct. There's about 350 million people who live in the United States, 350 million Americans. Would be about 200 million who would need to have protection, immunity, so that it would then protect the other 100 million or so. No one knows the precise number of people who've been infected with the virus. Let's say it's 10%. So that's 35 million, even rounded up to 50 million. You still have 300 million people who have no protection. And so you can imagine the toll that it would take if you began to infect all of those individuals. The description was in the 60s and 70s, kind of chickenpox parties, infect my child and then they have lifelong immunity. No one is suggesting that we go that far, but that's the tension. I am quite sure in the history of man, there have been communities that have developed herd immunity. I'm not an expert in that. But in modern society, that has not occurred. I'm sure sometime in the 16, 17, and 1800s, herd immunity was acquired, but at great cost to society. And that's why the vast majority of public health and ID people, the only reasonable approach is to protect individuals now and then to pursue herd immunity through vaccination. Now, the great unknowns are as if you get disease, are you protected and how long are you protected for? And will that depend upon your age or your gender? And it's just unclear. And the same will be true of the vaccine. If you get vaccinated, how long do you have protection for? And many, not many, but some have speculated that the vaccine protection from the vaccine potentially may only last a year, 2 years, or 3 years.
And let's talk about known cases, because you just said maybe 50 million. So there's a known case rate, which is, I think they say around 10 million, but then some people speculate it could be 5 or 10 times that number. And you mentioned 5 times that number. Is that still kind of is that a going rate, or how do you kind of calculate that in your head?
I think I've seen some high quality data that are making their way through peer review that would suggest somewhere between 10 and 15% of the U.S. population has been infected.
And children, of known cases, children make up 11%. And that's roughly 1 million in the U.S., that's roughly 1 million pediatric cases since the pandemic began. And of course, their fatality rate is much lower. I think I've seen it like 0.2%. And people talk a lot about what we accept as risk every day, like more people under 70 die in car accidents than from COVID. And we accept that risk. So is accepting a risk like that and saying, well, we should accept the risk in children, is that can you talk about if you think that's a valid point, or is it a non sequitur?
Well, it's not a medical decision. We can provide numbers and estimates, but then ultimately people have to make decisions about what they think is a reasonable risk as both individuals as well as societies. I think Sweden was willing to accept initially in the pandemic the risk of exposing more people in an attempt to get to herd immunity. Most countries really wanted to shield the most vulnerable, as did Sweden, because they thought the risk was too high. But in your own life, I fly periodically to see my family, but my family won't fly to see me. They're more risk adverse. So one sense of risk is very, very individual. So medicine or public health can only provide the numbers. How individuals and society and a society then understands that is far more complicated. My only other comment, Brian, is when people talk about children at 0 to 19 or 20 or 21, post-pubertal children, the data about post-puberty is generally considered to be different than pre-pubertal. And so I appreciate that people generally use the term children, but they have to be very careful in knowing that a 15 or 16-year-old individual who's gone through puberty, their clinical response is going to be more like a young adult than it is going to be like a 5-year-old. They're very, very different. And the change occurs obviously because of puberty from a physiologic standpoint.
And thank you. Actually, I was going to ask you to define pediatrics, and because when I was looking up some of these numbers, they're saying like there's a number for 0 to 5, and then that number increases 10% if it's 5 to 10. And so,
and those are just, easy categories to remember. I think most people who really think about child data really think about prepubertal and postpubertal, but you don't normally know the pubertal status because it can vary at 8, 9, 10, 11, or 12. So I think people usually talk about data under 10 or under 5 and then older 10. The real question is prepubertal versus postpubertal children.
I'm going to ask this next question. I'm going to set it up because it's an embarrassing thing to read about sometimes. And, and what I mean by embarrassing is I keep reading and hearing commentary, a lot of it's social media and online, that mortality is mostly in older people over 80, and somebody even wrote, people live the average lifespan 78 anyway. And that kind of commentary I kind of find off the mark and a little bit embarrassing. But I think what they're not getting is that in between asymptomatic cases and death, there's a massive amount of suffering, right? And you had talked about calculating, or not you had talked about, but I think I read in JAMA Online about calculating harm from excess death and whatnot. But how do you calculate that harm to families and individuals that between asymptomatic and death, all the rest of the disease? It's not one or the other.
No, but again, we can only help give people information, and then those calculations are complicated. So we had a series of articles about the economic costs, the mental health, and excess deaths. The one thing left out of that was educational costs. We can return to that. Larry Summers and David Cutler, two incredibly nationally and internationally renowned economists, titled, I think the piece is titled something like the $16 trillion virus. I mean, the economic cost is simply going to be immense for individuals, families, and states. It seems like the federal government just keeps borrowing money, but states can't borrow money. They're going to manage this year. Their real financial crisis is going to be next year. They're borrowing from the rainy day fund. They're moving funds around. But fiscal year, the calendar year 2021 is going to be just tremendously painful for states. And then you have the mental health or emotional costs. Now, those are evolving. So Charlie Marmar and colleagues wrote about kind of grief reaction and what percent he would estimate that could occur. And I think the estimate was 5 million people in the US would have a diagnosable grief reaction to the number of people who were dying in the country. And then one of the things that Jay didn't mention in the that came up in our discussion is if in fact the so-called long haulers, or if there really is a substantial percent of people who have long-term consequences from infection, be it asymptomatic or symptomatic, seriously ill or not seriously ill, that would be another reason not to pursue herd immunity, that you could leave a society with tens of thousands to millions of people who have long-term consequences of being infected. Those are all things that one needs to judge. Excess deaths, which is what we've tried to talk about through Steve Wolf's research letters and a number of viewpoints in JAMA. We know how many people die a year in the United States. Last year, I think it was 2.8 million people. We know how many people have died in the United States through October 1. It takes about a month to get the data. So when we talk about excess deaths, that's what we mean. And so this year, instead of being 2.8 million, it's likely to be 3.2 or 3.3 million people. So there's been 500,000 excess deaths, of which 300,000, 350,000 may be directly attributable to COVID-19. The other 150,000 are attributable to the pandemic and people not seeking care for myocardial heart attacks, or if they have a stroke or not getting exercise and dying because they didn't get exercise. So it's that excess deaths that I think is as important as when we say there's been 220,000 COVID-19 directly related deaths. And those numbers will become very clear. We do a very good job about counting the number of people who die in the US each year.
And you mentioned in that answer the mental health issues and the depression. That's going to be a long trailing thing if you have a family member that either was seriously ill and hasn't quite recovered, or a death. I mean, that's going to be years to calculate that kind of damage, I assume.
Yes, and we have a number of viewpoints coming up about mental health issues and particularly the elderly. The data are uncertain at the moment. Many of the elderly in certain surveys have actually done quite well. They may have levels of resiliency that we had not thought of. I think personally many of us know about the elderly individual who can't see their relatives or is in a skilled nursing home. But on some surveys of elderly community dwelling elderly. They've actually done better than I think people had anticipated. Whether they'll continue to do well is unclear.
Let's follow up with that a little bit about pediatrics and how they're, I'm sorry, children, we'll give an age range there, how they're doing socially, because I think I've read, these are self-reporting things where in a psychology journal, someone will do a phone survey. Do you think your children's happier, less happy, or the same? So I'm not sure how reliable they are, but I don't know, if you're talking about the data that you've seen in the elderly, have you also seen anything to indicate how children, school-age kids are doing socially?
There had been some early reports from last year when children began to Zoom from home about how well they were doing educationally. I don't know the details of those reports, but there was tremendous concern that children may be falling behind educationally months in comparison to previous years. And I think we will not know for another year or 2 or 3 or 4 what the long-term consequences have been by moving so much of education to distance learning. I think the reports that I'd seen in the spring represented the worst case scenario, in part because I don't think schools, teachers, students, parents were very prepared for what happened in April, May, and June. I hope that they're better prepared for much of the distance learning that's been occurring this fall, but I don't think we'll know for many, many months to potentially many, many years.
And I don't know if you can answer this question or not, but regarding social and mental health in children, can you help me out that children are fairly resilient, right? I mean, this is a terrible time to see all this on the news and your parents are worried, they might be out of work. It's got to have some effect on the family life and on the kids. But are children fairly resilient so we don't have to worry too much that they're going to be changed for life? Or I don't know if you can comment on that at all.
That's always the prevailing view, that children are very resilient. I think it depends upon the environment in which they're living and are raised. Some children will have great privilege and are likely to do fine, but others in communities that have been harder hit or may have less resources, there it may be more difficult. I think many educators are very concerned about the long-term academic implications of a 6-month or a year period of learning from home. That simply may not be as effective as learning in person. And I think you've probably read, Brian, of all the other things that happen in schools, school lunches, the socialization that goes on between children, which is not possible. So I think the only fair answer is to say much is unknown.
And I'm going to ask you kind of a nerdy question now about studies and things like that. I hope you don't mind. We spoke earlier about RCTs and peer review, and you had a quote in an editorial from JAMA that peer review is only one part of the process. Authors must be honest. They can't fabricate, falsify, or misrepresent data, all of which may not be detectable during review. But in between dishonest and honest, there's a lot of unintentional biases, I assume, that people don't realize, and some p-hacking, or such as stopping data collection prematurely, or rehypothesizing after your data is known, or which comparisons to make, and more like that. And the reason I'm asking this is because I've read recently a paper about papers that in the mainstream psychology journals, they're starting to do something called pre-registering, where people write the study before they collect data, and it kind of guarantees publishing, and then you plug the data in and it resolves those kind of issues. And I think when they did the study, they realized that when they do a pre-register report, they get 8% come up with positive results versus 30% if it wasn't pre-registered. I don't know if you have seen any of that or not, but I'm wondering if you have, if something like a pre-registered report would make its way into mainstream science journals, or if they're just a mainstream science, if it's okay to say that, it's just completely different than psychology. And I hope I didn't offend anybody by asking that. If I did, it's from ignorance.
So earlier we had talked about randomized clinical trials. For more than a decade now, randomized clinical trials need to be registered.
Oh.
But we know what the question is ahead of time. We know what the primary outcome is. We know when the primary outcome is supposed to be measured. And for the major journals, whenever we get a randomized clinical trial, we evaluate it versus what the investigators said they were going to do before they saw the data. So that is de rigueur for randomized clinical trials. In all of the major journals, they look at what's called the statistical analytic plan and the protocol. And our expectation is that authors will follow what they said they were going to do when they report the results. So people recognized in clinical medicine more than a decade ago some of the concerns that you raise, that you look at the data instead of the 6-month outcome, you're going to look at the 12-month outcome. In the major journals, that doesn't happen any longer. There's some rare exceptions, but the clinical trials reported in the major journals, all of the hypotheses are laid out before anyone sees the data. And that really has helped increase the quality of clinical data immensely. Now, people have been concerned about that issue with observational data, where not many authors register or provide information prior to looking at the data. And so there are concerns that people may have taken repeated looks at the data and then emphasize the more impressive findings. And that's in part why we're very careful about rarely allowing an individual who uses observational data to use causal language. That goes into our considerations about the language that we allow investigators to use.
Great, thank you. And I have one final question for you. Do you have, or you've seen any indication in which direction the data is pointing regarding whether or not COVID-19 is a seasonal disease like the flu, it's going to wave through every year, or if it's containable, meaning we can knock it down with sporadic outbreaks, or something that will eliminate through mass vaccination? Is there any data pointing anywhere yet?
It is not seasonal. I think people had really hoped that it would largely wane during the warmer months. I think there's substantial evidence to say that has not occurred. It may be less prevalent, but it's not nearly as seasonal as flu. I think there would be broad agreement about that additional measures beyond what we do with flu are necessary, even in the warmer months. I believe we may see some return to normalcy, if we ever really can understand what that would represent, sometime late next year. If there's a number of high quality vaccines become available late this year, the first quarter of next year, and that through the first 6 to 9 months of next year, we can vaccinate 250 million Americans, and they're willing to take the vaccine. I'm hoping that sometime next fall, we'll begin to see children return to school, young adults return to college, sporting events, Broadway, dance, all open up again. I can't imagine that happening before the fall of next year, because I just don't think we're going to be able to successfully vaccinate enough people much sooner than the second quarter or over the summer of next year.
Dr. Howard Bauchner, Editor-in-Chief of JAMA and the JAMA Network, you've been my guest today on 502 Conversations. I greatly appreciate this. You're really a good communicator, and you're able to explain it to me, so hopefully it makes sense to a lot of other people as well. Thank you so much.
Thanks, Brian. It really has been my pleasure. And I know it's been such a difficult time for people in the United States and around the world. And I just say to all of your listeners, stay safe.
Thank you.
Bye-bye.
Thank you so much.